All right, everyone be quiet because Patrick is talking. I got a couple cases for you which I found interesting. This first one comes from my good buddy Joe Brainerd. He's a highly skilled and highly qualified paramedic who runs out of Rossford now. You'll see him occasionally as he brings patients in. I think he goes mostly to like the Mercy side now and stuff. But I've known him for a long time, ever since he was a wee lad, just a young tech pushing people around. Good dude, and I'm proud of what he knows. So this case he sent to me, and there's a picture of him and his wife. That's one I could find. It's kind of blurry. But the name Brainerd is English or British, meaning courageous raven, which is pretty dope, bold raven, or associated with bravery and strength, possibly evolving from Old French for brave or Old English elements for hardy brave, and sometimes linked to brainy or furious, huh? It functions as both a surname and a given name symbolizing wisdom, intelligence, transformation, and valor, appearing in medieval England and colonial America. I found the more often I do these names, the more apt they are. That's pretty interesting. All right, so here's the history. 75-year-old female, right-sided chest pain started night prior. Oh, I forgot. Brainerd's name means ravens, and a group of ravens is called a murder of crows. I propose we need different terms for different groups of physicians. Like if there's a group of urologists walking down the hall, say, look at that stream of physicians. And for ER doctors, I propose we should be called a spaz. Like, look at that spaz of ER doctors over there. But I digress. All right, so 75-year-old female, right-sided chest pain started night prior, woke her from sleep, radiates to back, diaphoresis and fatigue, chest pain, back pain, and nausea. Shortness of breath, history of diabetes, CVA, hypertension, hypertrophy, or hyperthyroid, and tobacco. No recent surgeries. Meds, Plavix, B12, Nexium, Humalog, Losartan, Oxybutynin, Pravastatin, Lyrica, and Trulicity. Family history of diabetes and ACS. Initial vitals 141/101, EKG as above. Respers at 21 at 92%. All right. The value of any EKG depends on your pretest probability, so let's think about a pretest probability. 75-year-old female, right-sided chest pain started night prior. Things that concern me, number one, it started in the night. Remember, around 3 a.m. is the witching hour. That's when your platelets get more sticky and you're more likely to have these problems. And right-sided chest pain, okay? The classic is, central and or left. Right-sided is actually, I'm not sure if I'm saying the right term, sensitive or specific. I want to say specific for coronary artery disease. And 75-year-old female. Females over the age of 55 are notorious for presenting for atypical signs and symptoms for coronary artery disease. And radiates to her back, concerning, okay? Interesting thing here, from what's described, it sounds like started in the chest and radiated to the back, not necessarily started in the back and radiated to the chest. Diaphoresis, always concerning. When your patient sweats, you should sweat. Like, you can't fake sweating. Chest pain, back pain, and nausea, curses, shortness of breath. Diabetes, all right, yeah. Female diabetic over 75 with diaphoresis, I'm already quite concerned. Plavix med, family history, hypertensive, and a little hypoxic. All right, here's the EKG he sent me. We got nothing prior to, compared to, once again, I recommend you pause, go over the EKG, think about what your findings are and what your interpretation is. Remember, interpretation is the action of explaining the meaning of something, and always incorporate your pretest probability, i.e. your history, when you're thinking about your interpretation. So let's just go through it like we usually do. Rhythm strip, lead 2. Let's see, there's a PQRST, PQRST. All the P's are looking pretty much the same, okay? We're fast here, so we got sinus tachycardia. So sinus and fast. We're up in lead 1, and we're up in AVF, okay? So we have a normal sinus. While we're here, we get a little peak of this reverse delta, which seems to be a lot in our cases recently associated with mitral valve issues. You can also see it here as well and here as well. I mean, shoot, while we're here, there's also signs of atrial enlargement. So with the atrial enlargement and the reverse delta, suggestive of right atrial enlargement and or mitral valve problems, whether it's acute or chronic, I cannot tell you from this EKG. So for intervals, here's one QRS, here's another, there's the midpoint. I don't think it's too prolonged, but I would refer to the machine. We're going to talk about QT a little bit later in this video because this video made me doubt QTCs, but we'll talk about that later. The QRS, again, I refer to the machine, but we're looking close. I don't think it's over 3 boxes, so I'm going to say it's not prolonged. And let's look at our ST waves. Okay, we got some artifact up here in 1, but there's our J point. There's our ST segment. Not much deviation, but we do have this downsloping appearance of the ST segments, which I don't like. Okay, again, here's our PR segment. Here's our J point. Not much depression, but we have this downsloping, which I don't like. You know what, Patrick? Curses. I take back what I said. I am saying this is greater than 3 big boxes, and it is prolonged. It's up right here, so I'm calling that an incomplete right bundle branch block. And I am calling this point here the J point, okay? Because my foolish eyes were deceived by this slurring here. I'm calling that, since I'm calling that a fraction of QRS, I'm calling this the end of the J point. So I rescind my statement. I beg forgiveness from the electrocardiographic people. There is slight J-point depression in these leads of 1 millimeter. Up here in AVR, again, it's tough to tell due to artifact, but I do think there is some J-point elevation here of about 1 millimeter. Here in AVL, I'm not seeing much J-point deviation, and the T wave is upright, which is reassuring. Here in lead AVF, as we spoke of before, I am seeing some J-point depression as well as this fractionated QRS. Up here in V1, there's the PR segment, there's the J point, again, PR elevation. In V2, there's the beginning, there's the end. I'm not seeing much ST deviation, not much there in V3. We do have some J point deviation over here in the lateral leads, in V4, in V5, in V6, okay? And yes, the machine does say it has a prolonged QTC, and it does violate that rule of halfway. Okay. So overall, my findings are sinus tachycardia with a normal access. I'm going to say prolonged QRS with incomplete right bundle branch block appearance, prolongation of the QTC, as well as J-point deviation in multiple leads. Now, my overall interpretation for this, the 2 things I'm worried about is number 1, an acute infarct, and number 2 is a pulmonary embolism. Okay. All right. Now, this is just a close-up, so we can elaborate more on this. Again, this tracing has a lot of artifact, but over here in AVR, here is the PR segment, and here is the J point, and you can see there's 1 millimeter of ST elevation, and same issues here. It's much more elevate here. Okay. And again, sole elevation in AVR can be a sign of 3-vessel Ds or proximal LAD, which is not very specific. It's kind of sloppy. But elevation in these 2 contiguous leads is highly concerning for an acute infarct. Okay. Excuse me. All right, so here's what happens. CTA of the chest, acute pulmonary emboli beginning at the bifurcations of the right and left pulmonary arteries and bilateral interlobal segments and subsegmental involvement, associated findings of right heart strain. Interesting, like we saw in this EKG, we noticed this atrial enlargement and this slurring of the segment consistent with a reverse delta. I wonder if that's a chronic thing or an acute thing from this PE. I can't tell because I have no access to any previous, but that's interesting. I just realized that. Possible small areas of pulmonary infarction in the left upper lobe and lower lobes, cardiovasculars that can be seen with pulmonary hypertension, and potential acute or chronic. That makes sense as well, right? This large R wave here in V2, again, is associated with right ventricular strain. And like they're saying in this finding, is that acute or chronic? Hard to tell. Reflux of contrast bolus related to acute or chronic right heart strain dysfunction, mild bronchial while thinking potentially due to pulmonary vascular congestion, reactive airway disease, or bronchitis. Labs, troponin of 28. They pushed T and case on this patient, and unfortunately she passed away. Okay, so the teaching point for this EKG is not all ST elevation is coronary artery disease. Okay, here technically we do have indications of an acute infarct, both with symptoms and EKG abnormalities, i.e. ST elevation in AVR and V1 with reciprocal changes, But in this case, we found out that it was from a PE. All those other things which are interesting, including these signs of right heart strain, if we could confirm those were acute, that would further heighten our suspicion, but I don't have access to all those records. So that's case number 1. These next 2 cases come from Dr. Mohammed Butt. Excuse me, I got a drink. He's one of our first years. He's a good guy. He sends me cases all the time via text. I think he must think I think about him all the time, or I'm awake all the time, because I was coming at like 2:30 in the morning. I'll get like a text, like, school canceled for tomorrow? No. What's his EKG look like, Russ? I'm like, all right. All right, so I looked up his name. There was a couple different versions, like there was English and French. Forgive me, I'm not being xenophobic, but with the first name Mohammed, I assumed that his came from the variant of the Kashmir Baram surname Bhatt, often used by Muslims who migrated or adapted from the Punjab region. I'm not sure if it's Punjab or Punjabi. It means scholar or learned one, the most common meaning reflecting traditional roles in Vedic learning, philosophy, or scripture. Lord, master, meaning lord or husband, indicating respect or authority. Priest, custodian, used by Brahmins who served as priests, temple caretakers, and performers of rituals. Common among Kashmiri Saswat Brahmins, who were significant knowledge keepers, astronomers, and manuscript preservers. Again, pretty apt, like he's a nerd. Like he wants to know everything and he has never-ending questions. My one piece of advice for him is he needs to understand the difference between intelligence and wisdom. Intelligence is knowledge of others, and wisdom is knowledge of yourself. And true wisdom lies in knowing that you know nothing. Those are quotes from other smarter guys than me, but that's my piece of advice for him. So here we go. Here's 2:30 a.m. I saved a woman life today with EKG and ultrasound. Gave TPA based on ultrasound. My ultrasound, all caps. I took that EKG and stared at it for like 3 minutes straight, running around the ED with it like a chicken with my head cut off, looking for clues. He also sent me a clip of a bedside echo, which I couldn't get to load on this case here. Here's the EKG. Again, I recommend you pause and go through it. Think about your findings and interpretation. The interpretation is this pretest probability, which is Mohammed's a nerd. All right. Okay, so here's what I see. Once again, lead 2 for the rhythm strip. I do see 1P before every QRS. I do think it's fast, and I do think it's sinus tachycardia. Again, interestingly, we see atrial abnormalities here with these enlarged P waves here. And again, I didn't notice this before, like this reverse delta here as well, okay, in 2-3 and AVF. So sinus tachycardia, okay, for the axis, we are upright in lead 1. Note we do have an S wave, okay. We are upright in AVF, so we have a normal axis. For intervals, here's one QRS, here's another QRS, here's the midpoint, okay. It doesn't appear to be prolonged, okay. As far as the QRS duration goes, here's the beginning of the QRS, and again with this slurring, like you can't trick us, we're wiser than you, EKG, you jerk. We do have J-point deviation here in some leads, okay? Widening of the QRS greater than 3 boxes. Again, upright in the precordial leads, so that's consistent with a complete right bundle branch block. All right, rate, rhythm, axis, intervals, ST waves. So here we're on lead 1. I don't see much J-point deviation. Here in a non-desecrated lead in lead 2, I do see some J-point depression, again with the linearity and flattening of this ST segment. I see a similar appearance down here in lead 3 with a flat and or inverted ST wave, again with that reverse delta. Up here in AVR, I do see slight ST elevation approaching 1 millimeter. Here in AVL, I don't see much J-point deviation, and the T wave is upright, which looks good. Again, here in lead 3, it's kind of wonky, but there might be some J-point deviation, and again, this ST repolarization abnormality, and again, the reverse delta. Up here in V1, we do have this funky SS prime here, but not much J-point deviation. Here in V2, I'm not seeing much J-point deviation. You can make the argument this is a hyperacute T wave. Here in V3, I do see J-point depression as well as looks like a hyperacute T wave. And again, definitely a different R wave progression in precordial leads. I mean, because it's not abnormal R wave progression, because that has to be an R wave less than 3 millimeters in V3, which is clearly not. But the amplitude of this V3 here in V3 as well as V2, as well as this drastic jump, from like 0 to 4 to like 15, again, is suggestive, in my opinion, of right ventricular strain and or pulmonary hypertension. Whether that's acute or chronic, I can't tell you. I mean, just like the last EKG. Same things over here in V4. We do have J-point depression. Not much here in V5, but I don't like how peaky this T wave is here. And again, we do have some ST depression over here down in these lateral leads. So my overall findings is sinus tachycardia, normal axis, complete right bundle branch block with borderline prolonged QTC, with diffuse J-point depression and repolarization abnormalities, as well as signs of structural heart disease and right-sided heart strain, acute or chronic. I cannot tell you. What is this? Completely indicative. I can't tell just from this, but it's going to be a PE from how much Mohammed spazzed out on it, and it was. Excuse me. Did I miss? Oh, I messed this up. I did mess this up. I'm sorry. So I would defer to Mohammed as far as what happened to this patient, but apparently he saved us. Oh yeah, we know he pushed TPA. Sorry. Here's another text he sent me in the middle of the night. History of breast lumps with increased shortness of breath, increasing over the past week, but more specifically over this evening. This was peristernal short axis. Other than S1Q3T3, do you see anything else? And when he asked me questions like this, I'm not sure if he's trying to trick me to see how stupid I am, or if he's just curious to see what I see. So here's the EKG he sent. Again, let's go through it. Down here in lead 2, we do have 1P before VQRS. It's tachycardic. And again, we note this P wave abnormalities here. Interesting. So sinus tachycardia, up in 1, up in AVF, normal axis, 4 intervals. Here's 1R, here's 1R. There's where the T wave is. Yes, it is. The QTC is prolonged, okay? Again, here's the beginning of the QRS. Here's the end of the QRS over 3 big boxes with mostly upright R waves in the precordial leads, because this is with a right bundle branch block. For ST waves, again, we see J-point depression in these leads, 1, 2, and again, we see the reverse delta, okay, with this inversion. We do have this Q wave in lead 3 with some J-point deviation and T wave inversion. Again, we see what looks like now 2 millimeters of a J-point elevation with linear of the ST segment in AVR. We do see some J-point deviation here, but an upright T wave, which is reassuring. Not much J-point deviation. Again, the reverse delta, but this inversion and downsloping linearity is concerning. Here in AVR, we do have some J-point elevation with linearity. In V2, we do have some J-point elevation as well. In V3, we have J-point depression. Over here in V4, J-point depression, again with this linearity of the ST segment. Same issues here with linearity of the ST segment, and same here in V6 with linearity of the ST segment. I just noticed something. Like this reverse delta over here in V5 is pretty prominent. Like if you notice, these EKGs are pretty similar. Do we have those in the other ones? Do we have it here? Not much. We got like a front delta there. Well, let me see the other one. Oh, we do here. Over here in V6. We do have this reverse delta appearance over here in V6. See this? See this reverse delta? Like the slurring of the S wave there. Interesting. I just noticed that. So let's get back to the current case. Here is the EKG. Let's see if this loads. This one he did send me with a video. I thought it was up here. Son of a... Yes. All right, let's see what happens. Sorry it doesn't play, but it's a good picture of what we're looking for is bowing of the septum. This is a large right atrium here. I would defer to all the much more smarter attendings at your residency who know more about echo than I do. Here's the other thing about this. For these EKGs, we have, sinus tachycardia. This one has the S1Q3T3, but we have all these other abnormalities, including this ST elevation in AVR and V1. Again, the EKG by itself is not completely diagnostic. Like looking at this EKG specifically, like you can make the argument there's elevation in AVR and V1, there's depression in diffuse other leads. This could be a triple vessel disease or a proximal LAD occlusion. But at the same time, like in this case, in that first case, you could be like, oh yeah, all this other stuff, she's a smoker, she's got COPD, so all this other right-sided stuff is probably chronic, she probably has underlying pulmonary hypertension. But again, like as we saw in these other cases, in this case, it indicated a different pathology, which was the PE. And even though he didn't give me much of the history, which was guided by our pretest probability. Remember? Let's see, is this playing? Whatever. The other thing is we noticed that these EKGs have prolonged QTCs. According to the literature, again, which you can look at your leisure, there is some evidence that prolongation of the QTC can be observed with a pulmonary embolism. Again, these aren't the best studies in the world. It's not the most 100% sensitive and specific, but one more thing that could tip our decision-making based on our pretest probability. Yet another paper that says prolongation of the QTC can be associated with PEs. And that's, what's interesting here. When you read these papers, if you're going to agree with their premise, you have to look at their methods, because they define a prolonged QTC as 460. In this other paper, it was 470 and 480. The other thing about this was a QTC. Like, I don't understand how this is not prolonged. Like, the machine called it 450, but if you go to MD Calc, you can put in the reference things to measure out like the QTC for yourself, and they said, count the boxes between the QT interval, and I did, and when I put it into that machine, it said it was like 580. So I'm doing more reading on QTCs and machines and stuff because now I'm confused. But the short of this story is not all ST elevation is a STEMI. The value of any EKG depends on your pretest probability. As we saw in this case, we saw a recurring pattern, which was ST elevation in AVR and V1. I find that to be the most often associated with large PEs based on my own experience in the cases I've seen in the literature. I've seen other ones where it's been inferior with 2, 3, and AVF. But the majority of both which I've seen and read are usually V1, V2, and AVR. That's all I got for this case. I hope you enjoyed. Patrick is done talking. That's it, I guess.